Well, hello, everyone. This is Kurt Chase. I am a partner at Husch Blackwell, and I lead our healthcare, life sciences, and education business unit. And I want to welcome you today to the third installment of our Health Law and Innovation virtual series. Week one was on vaccines. Week two was on hospital physician integration. And we have a really awesome topic today with a really, really great expert panel to discuss virtual health. And I'm sure you will find it very enlightening. A couple of housekeeping items. First of all, I mentioned to the group last week when I moderated last week's session that in this work from home environment, I apologize in advance for any dogs barking or doorbells ringing. This week I have to add to my list, and that is roofing sounds, because it just so happens that this week my roof is being replaced. So hopefully you can all hear me just fine, and I've got my headphones on to block out the noise. So it's just the things we deal with in this environment we're in. Okay, so a couple housekeeping notes. There is an application icon at the bottom of the console. There are a number of them, in fact. One of them is a question box. Feel free to use that throughout the presentation today. We'll do our best to try to answer questions throughout the webinar and weave those into the conversations. If we don't get to your question or we run out of time, we'll be happy to follow up later with an email and try to address any questions you have. There's also a resource folder at the bottom, and in that resource folder will be a PDF of the slide deck and the presentation today. Although this is intended to be very much a discussion and a Q&A, I think the slide deck is to guide the conversation, but the substance really is going to be from our three expert panelists today and the conversation they have. To that end, there will also be a link emailed to you tomorrow that will have a recording of today's session. That's for you to go back and watch or share with somebody who could not make it today. For those of you that are seeking continuing legal education, this has been approved for that, and a certificate of attendance and the course information will be emailed to you as well. So, and then the final item is that we do like feedback. We love comments on how we can improve, and certainly any topics that you see that would be helpful for future webinars and presentations by our team and the great folks that we work with in the industry. So please fill out the survey and give us any feedback that you have. As I mentioned, this is the third in an 8-week session. You'll see here on the slide the next sessions that are coming up. It's a variety of topics that all have had or will have an impact from the COVID pandemic that we are facing. Risk management, strategic acquisitions, relief funds, pharmacy trends, all very important hot topics. And then the final one is going to be a legislative outlook, and we intentionally put that one after the election. And our panelists are going to talk about what they see coming in the future on the legislative side based on what we have as election results. So with that, we're going to jump in today, and the topic today is virtual health. Who will be leading tomorrow? CMS, consumers, COVID-19. And this topic is front and center of a lot of our clients and a lot of the industry providers and payors and pretty much anybody that touches healthcare seems to have come across issues around virtual health these days. What's happened, though, in the last 6 months is really unprecedented in the acceleration and the transformation of virtual care. And we're going to highlight some of those issues, some of the inequities that this has exposed, and the challenges that we have to address. And so that will be kind of the focus of our conversation. So before we get into the substance, let me introduce our panelists. Today we have Latoya Thomas, Sylvia Trujillo, and Julian Rivera. Latoya is currently the Director of Policy and Government Affairs for Doctor on Demand. Deep expertise in shaping statutory and regulatory policies on a nationwide level, and really focusing on facilitating a better delivery of care, cost reductions, and connectivity and transparency between consumers, providers, and insurers. So welcome, Latoya. Next, we have Sylvia. Sylvia is the Policy Director and Senior Legislative Counsel for Compassion and Choices. She's helped drive improved equitable access to end-of-life care for individuals with a serious or terminal condition, all while leveraging digital health options. And Sylvia, welcome to the panel today. And then finally I'm just the moderator, so I'm not the key part here, but Julian is a partner of mine in our healthcare group at the firm. He's in our Austin, Texas office. Julian's practice is primarily around representing providers and healthcare technology companies on a really wide range of issues that affect them in the tech space, on regulatory compliance, operations, transactions, litigation, payment issues, and the like. So with that, I welcome our panelists today. We have an outline that we're going to go through, but this will be a bit fluid, I suspect, as well. And I look forward to getting the comments from the panelists on their thoughts on what's happening. But the main topics we're going to try to cover in the discussion today are, first, what the pandemic has done in stress testing our virtual care infrastructure and what that looks like. Second would be more of the consumer-driven piece of this, given that shelter in place in many communities and certainly in some parts of the world, and maybe a restatement of that, and we may see even more of that in the United States, and how that's going to affect things. Third is kind of our state governments and CMS responses to this in two areas, basically the regulation, lightning and waivers, as well as payment options. And then weaved into all of these really is the effect of the what this has revealed in terms of healthcare inequities that exist. Before we jump into those topics, we're going to put out 3 poll questions. And for those of you in attendance today, I would ask you to respond to these. I'll give you about 10 or so seconds on each question. They're pretty short. We will try to take the information and weave it into the dialogue and the conversation that we're going to have. And for those of you that are seeking CLE, this is a required element. So it serves 2 functions. So our first poll question is, has your organization dedicated increased resources to virtual care in light of the pandemic? And your choices are significantly, moderately, about the same as it was before, and really just not applicable. So if you could take a second and answer that question, I'll give you just a few more seconds, and then we'll move to the slide that will actually show us the real-time results of that. Okay. So for about a third of you, it's not applicable, but for the rest of the group, pretty significant changes. So, and dedicated resources, not too surprising to me. So I'll give the panelists a second to see that. Okay, the second question. What do you think is the primary challenge facing virtual care? And you could probably pick about 3 of these. I don't think the software allows you to do that. So you pick the one that you think is the primary challenge. Investment requirements, capital, payment models, federal state regulatory issues, privacy concerns, patient access, or the infamous other. So pick the one that you think is the primary challenge that faces us today in virtual care. Okay, so the 2 that received the most responses are the regulatory issues, federal and state regulatory issues, and patient access. I'm sure there'll be a lot of commentary about both of those topics, but not insignificant were privacy, competitive payment models, and investment. So very good. And our final question before we jump into the substance then is, have you or someone you know utilized virtual care services? And we split this into yes, pre-COVID, and yes, since COVID, and then both prior to and during, and then no, not at all. Trying to get a sense of if you or someone you know has actually utilized virtual care. Okay. Wow. So almost 60% since COVID. So that's not too surprising given that how rapidly things change. So great. Well, I appreciate those answers. And so we'll jump into our substance. So our first topic and I'm going to pose some questions to the panel on this. And that is that, the pandemic stress tested our current infrastructure. And let me start. I'll throw it out to Sylvia or Julian. One of you maybe could start. And what do you see as the impact of these changes coming together simultaneously?
Sylvia?
Sylvia, you're on mute. We're trying to use our mute carefully. There you go.
Just panelists. So from a patient perspective, compassionate choices represents terminally ill individuals, are those with serious conditions. And what it meant is that a confluence of changes had to happen in a very small period of time. So essentially about 5 years worth of regulatory payment and infrastructure and workflow adjustments had to occur in the span of a couple of weeks. And as an organization, we had terminally ill patients that could not show up at hospitals who needed care rather immediately, and it tested the state of affairs throughout the continuum of care. People focused on hospitals with surge, but really the outpatient capacity was tested in an extreme way, and some had systems in place. So you had infrastructure that was turnkey for some providers. So for instance, there were some federally qualified health centers, community health clinics that had the infrastructure and the resources to transition essentially within a week, preparing both their technology, their workflow, their staff, but critically important, their patient population, identifying the technology that they were most conversant in, and then adapting the services that they could provide and prioritizing the patient populations that they were going to serve. So I've been in the digital health space for about 13 going on 14 years. And in the span of the last 2 weeks of March through April, we saw both federal and state policy changes around the regulatory payment and infrastructure front that quite easily probably would have taken about 5 to 10 years to do.
And we had been trying for 5 or 10 years.
At least.
Yeah. Just to add to that, one of the things that really helped was there were a number of organizations that were prepared to launch resources for the complexity of this entire thing. And so I think what we saw was that there was a closer collaboration between the claims folks and the providers and the folks in between in terms of coming to conclusions about what's appropriate, what can you get paid for, what do we need to be careful about, what's the reason why this rule exists or that rule exists. And at the end of this presentation, we have a slide for you that gives you hyperlinks to these resources. So, many of you, 60% of you said that you wanted regulatory information. We're absolutely going to address it today.
And if I could just add to that, for example, for those who were prepared and the federal regulators, Congress, and state regulators offered flexibility around medical practice, licensure, coverage and payment, and then made accommodations for the fact that we don't have readily available medical grade broadband everywhere. We saw that, for instance, Virginia Garcia Community Health Clinic, which is just a stone's throw from where I'm located, they had the infrastructure to essentially overnight go from less than 1% of telehealth visits to 75% of their visits were done virtually. And now they're sort of normalizing around 50%. But that normalization is not, as many of the people know on this panel and many of our listeners, is not a sustainable model without the same type of coverage and coding policies, as well as some modifications that reflect the evidence that we've garnered over the last 7 months about appropriate adoption and integration of services into clinical practice. In contrast, there were some providers, as many of you know, that wholly were unprepared. And we saw a really significant downturn in in-person visits without a corresponding uptake in virtual services in many physician provider practices that didn't have turnkey options available to them for virtual services. And so we've been trying to make up that gap, organizations like the AMA and others. But I believe that concerted building towards the future needs to continue as we also advocate for coverage and payment and regulatory flexibilities.
Very good. Well, LaToya, let me jump to you for a moment, and you're certainly welcome to tag onto that question, but I'm also curious, given your role at Doctor on Demand, how you see or how you saw providers respond to the changes that COVID brought to the forefront of virtual care.
Yeah, certainly. I will echo both Sylvia and Julian's statements, though, having also done this work for over a decade, there certainly was no lack of sweat equity pre-COVID in getting fundamental changes that could accommodate virtual care and telehealth at the state and federal level. So it was nice to see lawmakers and key stakeholders really come together and really put us in a position where we can better accommodate some of these changes. At Doctor on Demand, we're a virtual care practice. And so having telehealth allowed us to quickly adapt to the challenges of what we called the multi-demic. It was the challenges of COVID and doing our best to mitigate the spread of this infectious disease. It was leveraging telehealth to adapt to the challenges of certain triggers for behavioral health, whether it was intimate partner violence as it relates to folks having to be forced to stay at home. It was the violence-related trauma that was happening in some of our urban cities that we saw over the summer, the spikes there. It was some of the financial uncertainties and unemployment that we continue to see pervasive throughout our country, and seeing a spike in behavioral health visits as it relates to that. And of course, we certainly can't overlook the traumas that were inflicted by some of the social and racial issues that we continue to see played out on a national scale. For us, having a telehealth empowered interdisciplinary care team of primary care providers, behavioral health providers, as well as nurse practitioners, nutritionists, and pharmacists, we really were able to serve a vital public health role and mitigating the case of not just the infectious disease, but some of the other challenges that I mentioned. In early March, we developed a COVID center to provide online assessments and more information to patients. But we were also providing coordinated testing. We were tracking cases as well. And we developed new clinical guidelines for physicians. I think one of the things that's overlooked, and Sylvia slightly touched on this, is that we weren't operating in a vacuum. We weren't operating in a bubble. We were holding ourselves as a virtual care practice to make sure we were providing quality care through this virtual medium, which meant having our virtual care providers on both the behavioral health and medical side to update those clinical guidelines so that patients were getting the best treatment, the best care, and also receiving those services in an intensive care environment such as their home. We were able to mobilize to support the needs of the healthcare system, which we recognized were being extremely stretched at that time. And we were the first nationwide virtual care practice to enroll and serve Medicare Part B beneficiaries. But we were also able to provide affordable visits to both active and retired TRICARE beneficiaries and their families, as well as Medicaid and uninsured residents in other states. Leveraging a platform that enables longitudinal relationships really allowed us over the past few months to provide routine care, not just for those with acute and chronic conditions who opted to seek care in their home in order to prevent exposure to COVID. But as I mentioned before, we certainly saw an uptick in behavioral health visits from February, and we continue to see significant rises in behavioral health visits today.
Well, thank you. So, go ahead, Sylvia.
Can I just add, LaToya actually raised a really important point, and it's critically important now. as we're looking towards extending the flexibilities, there's a lot of questions about whether this is just about convenience and whether consumers just like this modality. In fact, what we've seen due to COVID is that this represents provision and of care and modality that can in fact be better than in-person care when you're talking about, in particular, certain vulnerable populations like terminally ill or with a serious condition, where going into a brick and mortar provider practice can expose them to increased risks of accelerated and painful death. But this is true even once COVID is gone. When you have a medically fragile patient who needs to receive care, care will be delayed if they have to go to brick and mortar. And it means that they're more likely to be seen in a higher cost center with worse outcomes in terms of the quality of care. So I thank you for that reminder, LaToya. It really is one that accelerated compassion and choices advocacy in this space at the state and federal level.
Well, thank you for those comments. And so that was really focused on the infrastructure. Let's move next to what has occurred in the consumer access and maybe some of the quality and patient issues. Sylvia, I'll start with you again. How do you see virtual care positively affecting quality?
So I'll expand on that comment, right? And that was really just a tee up. LaToya's was a tee up, and I probably anticipated it too early, but this is a classic example where you have high acuity patients, and it's often thought that the conventional wisdom is that high acuity, multiple comorbidity patients are not the ones that access telehealth, that it is the worried well and well-heeled that do. And COVID-19 has really laid bare that that is not true, that virtual care can provide high quality care in a coordinated fashion, guided by well thought out clinical practice guidelines, and that this can be done not only with consumer facing platforms like Doctor on Demand, but those platforms that are now transitioning more fully to integrate with existing brick and mortar practices to offer a full continuum of care. And we know that continuity of care is a very important prerequisite to the delivery of quality care. And so we have seen consumer-facing platforms and brick and mortar providers more fully embrace this important modality. And we've also seen that this has tremendous implications for public health. So quality public health cannot occur without a virtual option, whether we're talking about COVID-19 or we're talking about a catastrophic event like the fires that we all saw on the West Coast, where brick and mortar facilities overnight in communities disappeared, and surge capacity was needed to both recreate the clinician capacity, but also to access electronic health records and to maintain the longitudinal historical record of services that any given patient receives. And so we now know that you are going to be very hard pressed to provide quality care, whether it's in person or virtual, in a holistic way to any given patient if you are not incorporating virtual options to your delivery model.
So LaToya, I'm going to jump to you next, and I'm going to tag on to that a bit. So it's from the provider side and even the payer side, quality is critically important. And from the provider side, it's the number one importance of making sure that, good care is provided to the patient. One would think that quality and patient satisfaction go hand in hand. But from the patient's perspective, what should providers and payers be thinking about in terms of what the drivers are in virtual care to have patient satisfaction, so that they see the value, not just in the quality piece, but the value of the virtual care aspect?
Yeah, those are really great questions, and I don't think that you can't unbundle those two things, right? We know as a virtual care practice, doctor on demand, that telehealth enhances primary and behavioral health care when providers are demonstrating best practices such as establishing trusted longitudinal relationships, enabling follow-up care with the same healthcare provider, ensuring an integrated labs experience as well as smart referrals to other specialists if necessary and when necessary, but also ensuring care coordination. And of course, patient satisfaction is a huge component of this. One of the things that we are probably most proud of over the past few months, as you talk about stress tests, quality, and you talk about patient experience, we have a 5-star patient satisfaction rating system, but we also give the patients the opportunity to provide anecdotal reviews. And it's not of the technology. What they are reviewing is the actual medical visit that they've had with their healthcare provider. And we are super proud to have learned over the past few months that our patient satisfaction scores never dipped below 4.9 out of 5 stars. And we know that the entire healthcare industry, whether you're providing services virtually or in person, were pushed to the max, whether it was trying to support some of the capacity issues and making sure you had enough behavioral health providers that were on our platform. Whether or not we were having, we realized that our virtual waiting rooms were full. And so we had to create another virtual waiting room to accommodate the demand from patients, both who were insured or who were coming to us and choosing to pay out of pocket. So we had to create these workarounds in order to ensure patient satisfaction. I will add one more thing. One of the things that we realized pre-COVID when we created a virtual primary care practice was the need, and getting feedback from our patients, was the need to include trusted family caregivers in the discussion. And we weren't prepared in the first 2 quarters of this year to turn on the capabilities of providing kind of that third party integration. But what we were quickly able to accelerate as it relates to, as in response to some of the social isolation and stay-at-home orders that we all witnessed, we were able to quickly accelerate and turn on the ability for family caregivers, with the consent of the patients, to join in some of these healthcare visits with their loved ones. And it worked significantly well with our seniors because in addition to having experience in the Medicare Advantage space, at that time, we decided to really dive into Medicare Part B and be the first national virtual care practice to do so. So be able to virtually loop in some of these family caregivers into these virtual conversations so that they could, make sure that their kids who may have still been off to college at the time in the first couple of months of COVID, both March and April, and had not yet made their way back home, for some of those seniors that we know were staying at home to keep themselves safe during the COVID experience. But we were also able to measure the quality impact of our services, both from a chronic condition perspective as well as behavioral health. We looked at a panel of about 2,300 patients, and we looked at the effectiveness of our virtual care, which is predominantly video, but we also include omni-channels like text and secure messaging and audio if the patient requests it. But we looked at the effectiveness, and we saw that for those patients who were seeing a psychiatrist, which on average is about 4 visits, because that's how you adhere to care, right? That 60% of those patients improved the PHQ-9 scores, which is how you measure depression essentially. And so we were able to reduce depression symptoms amongst those patients. For those patients that chose to see a therapist or a licensed clinical social worker, typically on average, it was roughly 8 visits that they had, and we were able to see depression symptoms improve by 44% for those patients. We've also been able to see significant improvements in bad bad cholesterol among our patient panels, as well as improvements for diabetes, for their glucose levels. So it's been nice to see both our impact on quality, not just the volume of visits, but the quality of care that's been delivered, but also being able to sustain our patients' satisfaction for those visits as well.
Awesome. So Julian, I'm going to switch just slightly. It'll be the last question on this particular topic. And I didn't bring my magic 8-ball or my crystal ball for you, but I am going to ask you kind of what you think are the next steps on consumer platforms. So how do you see this working from a tech standpoint, and what do you see these platforms evolving into?
Well, we've had some good questions in the chat about both privacy and the FDA and medical devices. And I think the best orienting point to try to look down the road is the government's implicit, at worst, at least, acceptance of consumer platforms. And what they were betting on was that the state privacy laws and the efforts by consumer platforms had been taken care of. And the other part of that is that they lowered the enforcement, as Paul pointed out. They lowered enforcement, but they did not waive HIPAA. But it's going to be hard to go back and do enforcement if there was a good faith attempt. And a good faith attempt is going to be relying on the standard security and privacy protocols that would be in place regardless of HIPAA. So from my view, I think we saw a real convergence of a solution that is not in HIPAA. And I think we're going to see, particularly with the interoperability rule, I think we're going to see a real heavy push on HIPAA, and it's going to have to be a replacement. The other thing is that the use of mobile devices and remote monitoring, we haven't heard any stories of there's not a whole series of, or any that I've heard of problems with remote monitoring that cause patient harm, much less patient death. I got to believe that there were some. I got to believe there were some that may have been completely unrelated, but there's a question. But what the overall experience of this year has given the industry is that there is a solid, safe, useful platform to provide healthcare, and regulators need to get out of the way. But at the same time, the providers need to make sure that they're meeting the standard of care. And interesting to me is that there are many providers who, I think, naively thought that with the mandate from their perspective of the use of telemedicine, that the standard of care somehow changed, that they didn't have to get a piece of information that they would have gotten in person because they can't get it in person. And so I think we're going to see some adjustment of what is really necessary in the bricks and mortar H&P, but I think there's also going to be a concern that the standard of care is therefore changing. And so the standard around the country is, if the standard of care is bricks and mortar, and I don't think that we can rely on that. I don't think that, I think we're going to see real movement. We're going to need to see a real movement on how standard of care is defined.
Now that's actually a great segue to the next topic. So you teed it up well, and that is this changing landscape and the two areas of focus and the three of you can comment on any of these or other topics that are related to this, but the two areas of focus that we've identified here are the easing of regulations, at least through waivers or interim, and payment structures. And I think, without those two things occurring, we probably couldn't have had the progress that we've had so far. That doesn't mean we're where we need to go. So I guess, Latoya, I'll start with you on this one. Or actually, I'll put it open to any of the three of you, quite frankly. Where do you see this? So we see where it's come. We're in this interim period of waivers. We have, there's been a lot of movement. Where do you see it going? And as you comment on this, I'd be very interested as well on how kind of the care team piece fits into this. And one of you mentioned about how the family and the caretakers fit in. I'm really interested as well as to where you see this going and where the care team fits in. So Latoya, if you want to start, we'll start with you.
Yeah, I'm happy to. I think one of the things that we've identified are some of these archaic rules that have been temporarily regulated over the past few months and probably need a lot more permanence. Sometimes fit outside of telehealth, right? You don't need an explicit, language recognizing telehealth in order to permit it. One really good example of that is allowing for nurse practitioners to operate at the top of their scope. The Association of American Medical Colleges recently released a survey indicating that the projected primary care shortage within the next decade is going to be between 20 to 50,000 healthcare primary care providers, which means that we need to rely on our very skilled nurse practitioners in order to ensure that patients all over the country can get access to routine, but also comprehensive routine care, and more than what they're expecting right now, but also being able to leverage some of these virtual tools to do that. In order for that to happen, states, should remove some of the collaborative agreement requirements between physicians and nurse practitioners. There should also be an enhanced pathway for nurse practitioners to practice independently and again at the top of their scope to really address some of those provider shortages. I think the same can be said in the behavioral health spectrum of healthcare providers, where we know that there's a dearth of provider shortages, particularly for those that are treating pediatric patients, kids. But again, if you're looking at those who should probably be specializing in more geriatrics so that they're addressing behavioral health concerns related to dementia or social isolation, in order to do that, we really need to address ways in which healthcare providers can practice independently, but obviously come up with more streamlined methods for these healthcare providers to safely and practice across state lines, but also be held accountable for practicing across state lines as well. I think one other thing just to mention, because I think we can talk about Medicare all day, but I do think that we should give some light to Medicaid and the fact that there are 51, if you don't include the territories, but 51 different Medicaid programs throughout the country. And even though that to some degree they all have to offer the same kind of core benefit in order to get that federal matching, but the types of flexibilities that they have to cover telehealth enabled services, it runs the spectrum, especially providing those services within the home. But when you look at the number of states who have transitioned from Medicaid fee for service to more Medicaid managed care, more value-based approach to doing that, and partnering with health plans to do so, it certainly opens up even more flexibilities for those Medicaid managed care entities to be able to look at virtual care, whether in their existing network or looking at virtual care providers to address some of the chronic care management needs, gaps in addressing primary care and behavioral health as well, but also improving and enhancing patient engagement in some of those key populations. Unfortunately, the 24th Century Cures Act, which was passed by Congress a couple of years ago, requires every state to enroll their Medicaid providers, whether you're participating in Medicaid fee-for-service or Medicaid managed care. And every state has approached that administrative requirement differently. Every state has an application process, but every state, there are some states that require that the provider include a physical site address where the patient is going to be seen. And there are some states that haven't even addressed the ability for some of their patients or beneficiaries to maybe even travel to other states where they might receive care. As an exclusively virtual care provider and practice, we find it administratively burdensome that we can't apply to participate in Medicaid programs because we lack a physical site address where the patient is going to be seen. It's not the nature of our clinical practice, but we know that we do provide virtual behavioral health and primary care services like some of the brick and mortars in those key states. But addressing even just some of the slightest administrative burdens would enable greater virtual care participation from both from both brick and mortar providers, but also for virtual providers like us too.
So Sylvia, let me give you an opportunity to comment on the regulatory and payment structures.
Yeah, so I would like to also sort of build off of what Latoya said with a couple of caveats, I think, and also something Julian mentioned. So on the regulatory piece, there is no question that when you're looking at telehealth, interactive two-way video communications, that these flexibilities were needed both for COVID, and a number of those, in fact, a large number of them should carry over, although not necessarily all of them. We should follow the evidence, right? So we don't want to create two-tier systems of care where underserved communities, because they don't have medical grade broadband connectivity, don't get two-way audio interactive clinical options. They just get, telephone. We might need to do that right now, but we should be building systems that include everyone with the same quality of technological modality offerings that offer good quality care. So I think on the regulatory front, we need to address that. And then when you start talking about devices, so peripherals in the provision of even telehealth care or remote patient monitoring, agreed. We need some flexibilities on the FDA front. Having said that, and having spent some time representing providers for a really long time, I can say that we need to make sure that clinicians and providers have assurances who may not have the economies of scale like doctors on demand to really stress test their devices and to know that their devices have cybersecurity and that they have a good evidence base for a particular vendor, that we are leveraging associations like DIME, like the AMA, Texas Medical, that they are working on really providing recommendations about validated devices. We don't want clinicians, and certainly we do not want elderly, terminally ill patients or those who are very seriously ill to be using devices that don't sort of meet expectations. And I will say the regulatory regime with regard to HIPAA issues really does need to address something that Latoya mentioned, especially as we have a rapidly aging population. We have to ensure that everyone can work at the top of their license. And I would add in pharmacists, medication management services for senior populations who tend to have more polypharmacy. They're not able to go in person oftentimes to have those discussions with their pharmacists. And it's a great way to relieve clinicians, both physicians and other allied health professionals who may not have the time to do that type of work, who can really aid individuals who have policy pharmacy and who may be terminal. Having said that, I really don't think that terminally ill or elderly patients deserve like a different standard of care than all the rest of us. And so I think it's important to ensure that they continue to have, when we talk about payment and network adequacy, that we ensure that insurers will provide, especially for vulnerable populations, pathways to access both in-person and virtual care. Right now we're fighting for virtual care and advocating for it, but we also need to make sure that we're, once again, not creating a two-tier system of once we get virtual care for everyone, and then we lock the door for in-person care. And to that last note, I just want to champion and echo something that Latoya said, both on a personal level and in the work that I do for Compassion. The telehealth services for palliative care not only were essential during COVID-19, but these are services that we are going to need, whether they're provided by an MD, a DO, an APRN. This demand is going to go up pretty dramatically, and we know that individuals with this type of training, whether it's palliative or other comfort care services for individuals as they approach death, that these services get to scale. You're going to need virtual options for them that include, with their authorization, family members. So, and yet, one of the palliative care physicians that we work with very closely, who offers the telehealth option, had indicated that with the rising flexibility, more families were able to include not just the family member that lives down the street that they were quarantining, they didn't see because of quarantine, but it included family members from around the country, and it allowed them to do advanced care planning at a time when this is more important than ever before.
Well, thank you for those comments. So we have about 15 minutes left in the time here, and we have about 2 slides to get through. So what I want to do is, number of you have mentioned kind of the next topic interspersed with your various comments, and that's really the exposure of healthcare inequities that have occurred and do occur, do exist. And one of our we got a question in that kind of goes to something you just touched on, Sylvia. And Julian, I'll jump to you next. And the question was related to this: how do we make sure we have good access? Virtual care is great, but how do we make sure we have good access to technology for those populations that maybe don't have it or need it? And so, Julian, as we look at the healthcare inequity issue, I'd like you to start with talking a little bit about what those inequities are and how we're going to start addressing that. And then I'll jump to Sylvia and Latoya for some comments as well.
Yeah, I think my view is that healthcare inequities is going to be driving healthcare. If you stop and think about how many times did you have a conversation before COVID about healthcare inequities? I mean, a real business conversation, not just, oh, we should do this and it would be good for us to do this with the community, but a real in-depth attack on healthcare inequities. The truth is that very few people had that as the core of their business or their practice. And I think that now we're in a position where we see that AI is dangerously discriminatory. It's easily discriminatory. And we're using AI in order to facilitate telemedicine. We're using AI in all kinds of different ways. And what we're finding is that engaging the populations that don't have access to technology are not only not getting a chance to try out the convenient technology, but more importantly, when medicine became virtual by necessity this year, what change was made to get that virtual technology into the homes of the elderly? What change was made to engage the home health workforce to pay them, for God's sakes? And number two, or whatever number I'm on now, pay them and then establish a platform and encourage a platform for getting technology to these populations. That takes segmenting of populations. And the honest to God truth is that we have been segmenting populations by race and ethnicity, and it is medically relevant. So if it is medically relevant and it is a valid measure of comorbidities and more, then there should be a direct investment of resources, not just money, but people, technology. And think about the power that many, many providers deployed earlier this year to put mobile devices and peripherals into the home. They were able to watch medication. They were able to watch situations of housing and be able to see where the need for housing adjustments need to be made. They were able to see the culture of the patient and feel the culture of the patient. So this list of things that we have, when we say stress test, we failed with healthcare inequities and we made it worse. We made healthcare inequities worse because we made it harder to get healthcare if you don't have access to technology. This is not an expensive proposition. It pays for itself at many, many levels. The problem is that the payment of long-term home care or home care at all is so pitifully low. And the trust that regulators and payers have in the quality of that care, there's a slammed wall that we're facing. We're not even addressing that issue. So I think, again, from my perspective, healthcare inequities and the social determinants of health, if you're going to stay in compliance, if you're going to avoid discrimination claims, and most importantly, if you're going to improve the health of the population that you're responsible for taking care of, you need to make absolutely sure that everybody has access to the technology. And a single provider may not have that power. They certainly don't have the power to generate broadband or get broadband into the house or Wi-Fi, but they can certainly partner with people and they can pay for that, the ability to get on technology and get people in the home to train people on how to use the technology.
Yeah, I would certainly echo that. Everything that Julian has said and said so poignantly. Thank you so much for articulating it so well. We know that research shows that 80% of clinical outcomes are driven by social and economic factors. So when you talk about segmentation, yes, it's based on race and ethnicity, but also gender and income. And so we understand that when we're talking to some of our payer partners, whether they be on the commercial end, whether they be for the government end like Medicare or Medicaid, or talking to our employer partners, what we're seeing is this overwhelming trend for folks to try to figure out how they can enhance access to primary care because it provides routine care for their entire healthcare population, but it also provides a comprehensive level of services. And more specifically, looking at an omni-channeled approach to doing so, but really powered by video, because with the use of video, you can establish a level of rapport with a patient that you couldn't necessarily do using some of those other channels or tools where you're not actually seeing and interacting with the patient. But to Julian's point, when you look at the influencers of healthcare, the social and economic influencers of healthcare, you can easily see those things when you're leveraging video. You can easily see the condition of a patient's home. You can kind of break down that fourth wall and have a much more compassionate conversation with them. And we produced a study that's been published in Mayo Clinic that really talks about what drives patient satisfaction. I look at the narrative responses that we get from some of our seniors, both in MA and the Part B work that we do. Overwhelmingly, what we're seeing in terms of responses from them is that they appreciate being listened to. by their healthcare providers, that they feel that this was the first time through this virtual care visit that they were actually listened to by their providers. And then we're seeing them follow up 3 to 4 months later because that's the care plan that their virtual care provider laid out for them. So we're actually seeing an adherence to some of those care plans as well. I will mention just one more thing. I know that Sylvia has a lot to talk about on this particular topic, but I also think that we can't overlook the power of a diverse clinical workforce. And there's a lot that can be said about how, and obviously should be said about inaccessible broadband and cellular data and unaffordable devices that we know empower virtual care and telehealth. But I think there's something to be said for telehealth's ability to extend the clinical capabilities of a diverse clinical workforce when the practice has so. At Doctor on Demand, we're really proud that 20% of our physicians are Black, which is 4 times the national average. 43% of our clinicians identify as ethnic minorities, and 60% of our physicians are female. And they choose to be physicians at Doctor on Demand because they understand the flexibilities that we accommodate for them to be able to both be working physicians using this platform, but also being able to take care of their families as well. And so we're proud to be able to do that as a practice, but we're also proud to be able to leverage that and scale that to patients all across the country.
So I would like to shout out both of those comments because I think they capture it accurately, and it won't be a lengthy response, but I will observe that we're talking about healthcare delivery. COVID-19 has really been a crucible of our public health infrastructure, which was non-existent in many places, I think we can safely say, and our healthcare system. And the healthcare system was not up for the challenge presented by COVID-19 and really adversely impacted vulnerable populations. A couple of points. I think broadband is not a sort of side note to social determinants of health. Broadband is a social determinant of health. It is also a social determinant of many other important factors that build into social determinants of health. If we do not have widespread broadband access in this country readily and easily available, we are building a house on sand. So it has to be an all-in call to action that we all must be pushing for if we want to build structural equality. And I do think, for instance, paying for services, physicians and other clinicians, just like us, we show up to work every day to get paid. It is quite reasonable to ensure that we are paying for the services and the products that we want them to use in the delivery of care. A quick example, remote patient monitoring codes. The technical component, which are the devices, CMS decided, Medicare decided not to value the cellular cost per device. That is a structural inequality. It turns out that I can pay for the cellular services on my device. An individual who lives below the poverty level does not. And so it is quite essential that we are not, while we're building this new world of 21st century medicine, that we are not reinforcing existing structural inequality and building additional ones. And I will observe that, to LaToya's point, not only in the clinical healthcare side and clinical care side of the house are we talking about representation of individuals and amplifying and multiplying their presence through virtual services. I will see on the public side of the house. So in North Carolina, Latinos, I think, represent about 9% of the population. In April, they were 70% of the reported cases. This story is repeated for African Americans, for Latinos, and for Native Americans, and we've all heard about this, and Asian Americans in certain parts of the country. So I think one of the things that they were able to do in North Carolina, and I know Compassion and Choices has been able to do, is that we've advocated for instance, bilingual services. So we immediately translated all of our materials on the COVID-19 toolkit, including information about telehealth and telehealth providers who were available in Spanish within weeks. And it's because the representation of our organization, and we had advisory councils. So I think that awareness is not because people are intentionally ignoring communities. It's that if you don't have representation in the room, you don't necessarily think about this. And I'll just use one last example. Nationally, many academic centers launched COVID-19 trackers. Only one was available in Spanish and English. And that one offered the services in Spanish and English because a group of Latino professionals who happened to know them said, is this available in Spanish? We'll promote it if it is. So those are examples of how common sense, very easy, digestible, pieces of food to eat so that we can grow into a fully equitable system are readily available to us. And no fingers need to be pointed. All we need to say is that we can actually build it and that there are incremental ways that each one of us can contribute to it.
Well, that's very helpful. The last slide is a list of additional resources that are available out there from a variety of places. I know there are a lot of other sites that have put out a lot of information on virtual health and toolkits and so forth. And, this is an area that clearly is going to constantly be changing, one where we have to stay very up to speed. And I want to thank the panelists today because they've given us a lot to think about. And certainly, this topic is going to be on the public conversation for quite some time in a good way. We are at our hour. And so we'll stop here. I do seriously want to thank all three of you for participating. Their contact information is in the materials. It's on the screen. And, really appreciate your time and your expert analysis. Just as a reminder, we have 5 more sessions coming up, so feel free to register for any or all of those. And a couple of other reminders, if you need the legal education credit, please hit the CEU icon at the bottom of the screen, and you'll get the email with the link for the certificate as well as the recording of the information. And last, please fill out the surveys because we do value that and those opinions. So thank you all for attending, and wish you the best for the rest of the week. Stay safe.
Thank you.